Hi, today we will talk about quality and competence in ERCP. This lecture will be accompanied by lots of pictures and practical aspects, and hopefully it will not be that dry, as most guidelines tend to be quite dry and inconclusive. So I hope to bring you some nice aspects that will have lots of clinical applicability. These are the conflicts of interest. Essentially, competence leads to quality. The technical complexity and potential risks of ERCP are quite high. And the quality in ERCP depends mainly on the skills and the ability of the endoscopist. Of course, other aspects such as X-ray machines, fluoroscopy, endoscopy unit staff helps. But it's the endoscopist who will define mainly how good an ERCP is done. Therefore, training and expertise improve the efficacy and safety of ERCP, and skills and ability lead to quality. So how do we achieve competence? Well, it's essentially that we get to know the theory. This is done during training. Then you watch the expert who is your attending and hopefully will be your mentor teaching you. But you can watch other experts, visit different centers, and see how ERCP is done. It's always better to see how multiple experts do the procedure. Then watch videos. There is lots of information on YouTube, on the internet. You can buy some videos, become member of communities that focus on quality, visit congresses. Then comes the aspect of tutor and apprentice. So you have your mentor or tutor and you are the apprentice and learn and get feedback. And it's very important in my view is that you also acquire skills handling and spatial concepts using ERCP models. You are already performing ERCP alone before you completed these 5 aspects. So you are already doing ERCP at the moment that you have your tutor and you are the apprentice. But then you need to continue doing models, go to workshops, then you go back and do more ERCPs, you continue to watch videos, you continue to watch experts. I have been doing this for more than 25 years, and the more I see, the more I learn, and the circle is a positive feedback. And I also know about theory. I'm always learning about theoretical aspects. So I think this leads you to the LLL, the lifelong learning process, which is ERCP, to me one of the most fascinating endoscopies. And so you can improve your skills and quality delivered to your patient. I'll show you some examples about knowledge. Quickly going through, of course, anatomy, but it's important that you know how the bile duct essentially is constructed, that the right hepatic duct branch is shorter and the left one is a little larger. You need to know the anatomic variations. Don't be surprised during a procedure when you are seeing strange configurations of the bile duct. You need to know your classifications for strictures, for bile duct damage, such as the Strasberg as well, or the Dubois qualification for patients who have post-liver transplant damage. It's essentially that you get to know the papilla, watch many pictures, watch many videos, look at the papillas. There is many classifications. This one is the one from Haraldsson. Based on the appearance of the papilla, one can anticipate whether the cannulation will be a little harder or less. As mentioned before, watching the expert is very important. And one aspect that I always tell my fellows and the visiting experts and doctors is you need to watch the hands and the movements, the scope, how the expert handles it, and not fix your eyes just on the screen. Because you know the theory, you already saw thousands of pictures of the bile duct and papilla. You need to see what's going on. How are the wheels being moved? How is the handle of the scope being handled? What's doing the expert to translate the movements of his hands to the tip of the scope when he's cannulating the papilla? This means while you are watching the expert, you will be very busy going from watching his or her hands and her body movements to the screen, X-ray, endoscopy, field, etc. It's very important that you learn to see cholangiograms, but it's also very important to know the principles of doing cholangiograms and how to avoid making errors when reading cholangiograms. So it's good to get yourself a good book, or as mentioned before, be in a community that is actively showing lots of cholangiograms and tips and tricks. Look at the internet, etc. So what's the best format of training? So I think that the best training program should include theoretical and practical tuition. So for the indications, contraindications, know the instruments and accessories, the various ERCP techniques, adverse events and management, knowing what happens to the procedure, because doing a procedure and letting the patient go home, and then if there is a problem that this patient is admitted at another hospital, is to me somewhat incomplete. And ideally, your center should have the alternative approaches just in case the procedure lacks or fails. Very important question that everybody asks and nobody knows what's the answer. How many ERCPs do you need to achieve competency? I don't think that an arbitrary number of procedures will define proficiency. This applies to any endoscopic procedure. To me, the key aspect of becoming competent in ERCP is that you have a trainer, a mentor, a tutor that supervised you and got to know you, and he knows or she knows when you have acceptable rates for completed procedure. This sounds a little subjective, but as you will see, it's very objective, because nobody else than the tutor will know what you're able to do, and of course yourself. But this is an essential establishment for quantifying competency, because competency is not only about numbers, but it's about quality. And this quality will be provided to you by your mentor. As mentioned to you before, watching videos, visiting congresses, and becoming members of communities or societies is very important. There are ongoing lectures and congresses and symposia in the internet. There are congresses in Spanish and English, in all German, all languages of the world. So you choose what language you want, and you get your continued medical education and improved skills in ERCP. I like models of ERCP, and there are lots of them, very reproducible models to do. There are wet models with live animals and pig stomachs. I have never done a live model ERCP, and I don't think they are worthy. To me, killing an animal to do an ERCP is not worthy anymore, especially if we can do it on pig stomachs, chicken hearts, as I will show you, and dry modeling. Dry modeling is very easy, and essentially in ERCP what you're doing is trying to get skills of handling, skills of the hand, and spatial tridimensional configuration and understanding. And furthermore, if you use wet models, you need to have special scopes. So we had to buy one when I was teaching my fellows and doing the studies for models, but it's expensive. buying even used ERCP scopes. By using dry models, using a mannequin or a plastic box like I will show you, you can use the same scope you're using at the hospital. It will not get contaminated, it can be cleaned again, and the skills were acquired. As mentioned before, enhancing the manual cognitive aspects are essential. So here we are with my friend, Dr. Marco Aurelio da Assunção from Brazil, who is a master model in the world. He really knows how to do models and has ongoing programs all year long in Brazil and elsewhere in the world. Here we were in the USA and bought a mannequin, and then we are here preparing the mannequin. I show you how it's being essentially cut in two. Using this mannequin makes an endoscopy a little more a life experience. Here is the way on how to prepare the esophagus and how to place the wires and the clips so that you can apply energy, especially if one is using a pig stomach to do interventions. But look at this simple model that we invented. This is just a plastic box. We created a lot of papillas with bile ducts and pancreatic ducts, right and left ducts, and we attached it to tubing that was the duodenum. And essentially through a hole we attached the tube that was the duodenum, and there you can advance the endoscope and cannulate the papilla and do different aspects: selective cannulation, right left, PD cannulation, insertion of stents, etc. Here you can see how the trainee is moving the endoscope, learning how to handle it with endoscopic view, which is essential. So here the tutor can tell the mentee, the mentor can tell the trainee how to move with the wheels, how to move the scope, how to get the best view. This is essential because if you only train with patients, that's not going to be as efficient and qualitatively good as if you already come with some skills in your hand. Here we show you how a mechanical ERCP training that existed was used to improve. So we took this training model and essentially evaluated how efficient it was to perform several aspects, including positioning, visualization of the papilla, insertion of guide wire, cannulation, and insertion of a plastic stents. So this model is quite nice. This was done by Cook, and it's provided to several centers at no cost for training, but you need to obtain it, and it's not always easy to get this model to be in your center. But the important aspect is what we're showing here. It's very important to use some static model to learn how to move, how to do the handling, how to do the endoscope. Here we're showing all of the manual cognitive aspects that are developed by using these models in ERCP. Here you can see the papilla. Then the papilla is positioned perfectly. Cannulation is then achieved while the trainee moves the wheels up and down, but sometimes the skills are not there. Still, they are learning, and the mentor mentions how to move the wheel up, how to push the scope down, or advance it deeper, pull it back a little bit. how to place the stent, at what moment to move the wheel back so that the release of the stent is appropriate. So I really think that this can enhance and will enhance the skills of any endoscopist. And these models are not only good for trainees at the beginning of the career, but ongoing. They are quite nice because not everybody places enough metal stents, for example, during training. And here you can place as many metal stents as you want, because we reload the stents and replace them over and over again. Here is an example of a metal stent that was placed. We also worked on a chicken heart model, as you can see here. This is very nice to perform incisions in sphincterotomy, especially pre-cut papillotomy. So it's essentially chicken hearts that mimic the papilla. The good thing is that we can use one pig stomach and then attach as many papillas as you want. One time we attached 10 different papillas. Here you can see 2 papillas attached to the stomach, and here I show you the model from Professor Rustemovic from Croatia, who is a leading expert in the world using models to train. There is high quality ERCP in Croatia, especially because there is ongoing trainings such as this one. Here we attach the chicken heart to the stomach, making a hole, and then this is a fiberglass stomach that was created by one of his friends. We use a plastic box, but you can see here that Professor Rustemovic has a special endoscopic views, as you can see during the procedure. Here a sphincterotomy is being performed, and you will see how we also can look at different settings and learn how you can cut or coagulate or do blended while you're doing the procedure. Here, training in pre-cut. I think this is fantastic that we have a model where you can essentially do a pre-cut like this instead of having to do a pre-cut for the first time in your life in one patient. So this leads to a quality. And what's quality? By definition, quality is superiority or excellence of something or somebody. So I think that the best way to say it is you need to do it right and do the right thing. That's what's quality for me. So we have been working as a group and together with lots of friends around the world. And as you saw, we developed several models with Professor Rustemovic, with Professor Jovanovic from Serbia, with Professor Marco de Assunção from Brazil. So we have established like a nice worldwide network that enables us to learn from others and become better. So who defines quality in ERCP? Is it the patient? Is it us? Is it the ESG, ASG, the WIO, WGO, or the government? To me, the worst part would be that the government comes and tells you what quality is. So in my view, is that quality is defined, of course, by the patient with the outcomes, but by ourselves. We are the ones who define quality because we want to do the right thing. And quality starts from the beginning. We need to be very compulsive and perfectionists. For example, if you look at this picture, there is a lot of things wrong with this picture. And you see, there are no protective gears placed, no masks, or like no gowns covered when you're doing a procedure. The scope is being held completely wrong. It was probably just held for a picture, and it doesn't have a button. But for somebody who is looking into quality, everything needs to be perfect. And this is what I want to tell you. You need to be compulsive and looking for perfection in everything you do from the very beginning. There is societal guidelines that can guide you, but sometimes I have some problems with some guidance because you see they are not complete. And for example, here it says that prophylactic antibiotics, when they are needed, need to be given in more than 90%. No, if you need prophylactic antibiotics before ERCP, they need to be given in 100%. If it's less than 100%, there was a quality issue that was not followed. And essentially, a procedure cannot be just complete just by bile duct cannulation. The bile duct cannulation needs to be defined. Is it just native papilla, or is the papilla invaded by a tumor? Because quality also means being able to say no, because if the endoscopist is just trying to cannulate any papilla to achieve a cannulation rate of 90%, when the papilla is telling you that it's not possible to be cannulated, that even before you attempt to cannulate, another procedure shall be done, EUS guided cannulation, PTCD, etc. But some of these guidelines, essentially, I have the impression that encourage the endoscopists just to sometimes do more and not do a step back and say no, because quality is also being able to say no and choosing another option. And so on, we go on, like complications. Well, it depends where you work. If you work at the university place where you have a lot of referral of patients who have had previous procedures, there might be more complications in your place. So there you will not reach the quality standards set by the society, because you are just doing a lot of more complex cases. So all of this is a relative aspect, and to me, guidelines remain as a guide and are not set rules, and a lot of guidelines require a lot of improvement because sometimes what they write is quite superficial. So quality ERCP needs to be safe. You need to think on the patient, and you need to know when not to continue or do more, or when to do more. It means that the exam needs to be well done through skill, competence, and ability. It needs to have a diagnostic consequence and therapeutic consequence, because what's the quality when the endoscopist has 90% cannulation rate, but there was no ability to place a stent, or placing a fully covered metal stent, or the wrong stent was placed, or the wrong therapeutic decision was done. So this is quite important. It's not just cannulation that defines quality, it's also the therapeutic consequence. And the procedure can be done in the best possible ways, but what if there is no documentation, no communication with the referring physician? This results in less benefit for the patient. So all of these aspects are very important. We propose to use this checklist. It's a mental checklist, lab scope. L stands from laboratory and x-rays. Whenever you're going to do a procedure, think of all the laboratory, the x-rays, review the x-rays before doing it. A stands for anticoagulation and antibiotics. Visit the patient and get the medical history, and talk to the patient, see the patient. Is the patient going to benefit from the procedure? Then think about the sedation, talk with the anesthesiologist. If you need anesthesia, the consent needs to be properly done. A patient needs to be NPO, and this needs to be also written in the chart. What is the preparation for the ERCP that's needed? And also know what equipment you anticipate to use, because sometimes not all endoscopy units have enough plastic or metal stents, or pancreatic stents, for example. Do they need to be ordered? Or if you have them in your unit, they need to be available in your room. So we think that this checklist developed by our community is quite useful, and if you follow all of it, I assure you, you will not forget what to do or what's good for the patient. And when doing the report, a quality report needs to have these elements. So every report needs to have date and place, endoscope used, utensils used. There are stickers that you can place on the report. Who was the endoscopist and the assistants? What was the anesthesia and sedation used? Essentially, it's a key that there is an indication or a brief medical history written, what medications were used. You need to have findings. It does need to be a novel. It's key findings that you write in your report, and photo documentation, pictures and x-rays. The dosage needs to be always written, and there needs to be diagnosis and impression and recommendations. In sum, competence, which are skills and ability, leads to quality. And the technical complexity and potential risks of ERCP are really high. Therefore, we need to have high skills and ability from the endoscopist to provide top quality. Therefore, training and expertise improve efficacy and safety of ERCP. Thank you very much, and I hope you enjoyed the lecture.